Good afternoon, friends. Thank you, ISA Trishur, for this opportunity. Today, in the next 20 minutes, I will be talking about a cocktail or mocktail. Is it worth to get a shot if I get infected with COVID? What are these monoclonal antibodies cocktail? These are the agents which are produced from the B cells of the patients who recently infected or immunizing mice that has been genetically mutated to humanized immune system and harvesting effective antibodies from them. And these B cells are identified and the genes for immunoglobulins are recovered. And these genes are then cloned to produce these monoclonal antibodies. And these are a type of therapeutic agent under the investigation for this treatment of COVID-19, which we are talking about. If you see this pictorial diagram, which represents these targeted WBCs, which actually produces the antibodies in a mice or a genetically engineered way. Monoclonal antibodies are not a new things. They've been available in the prophylaxis in the earlier, in the form of for rabies. We have few brands like that, which you can see in this slide, and also been available in the Ebola in the previous time. And they have actually have a singular target organ or target cell, so from which are different from the convalescent plasma, which has a polyclonal antibodies. So just to differentiate what exactly is a monoclonal antibody, different from a polyclonal antibody, if you actually take the convalescent plasma, which is produced in any plasma of an infected patient, these are a mixed population of antibodies which are available in this plasma, which may target different sites of the antigen, whereas the monoclonal antibodies, which are actually single antibody spaces targeted against a particular antigen epitome, and these may be recognized a particular protein and which has been a targeted monoclonal antibody. That means polyclonal antibody are just a combination of multiple things which are not refined, whereas monoclonal antibody is a refined form of antibodies which will be targeting a particular site like spike protein. So coming to the COVID, these monoclonal antibodies which target or spike protein, the COVID-19 virus, the SARS-CoV-19 virus attacks our cell through the a spike protein which is attached to our ACE inhibitors receptors. These monoclonal antibodies bind to this spike protein and prevent the invasion of these viruses into our cell. So this is how this theoretically the concept of monoclonal antibody use has been come into place. There are two kinds of MABs, that monoclonal antibodies which have been created. Eli Lilly and Regeneron has created this. The Eli Lilly's combination was bamlanivimab and isitivimab, and Regeneron combination, which is Regencov, that is a carcirimab and imdevimab. So these are the two combinations which are available from these two leading brands, Eli Lilly and Regeneron, and they are called from Eli Lilly as Liskov and Regeneron as Regencov. These are the two available combinations across the globe. A combination of antibodies that binds to a non-overlapping epitopes. We have been talking about why a cocktail, why not a single monoclonal antibody. The reason is a combination of antibodies that will bind to a non-overlapping epitopes rather than a single antibody, that is reduces the possibility of lack of effectiveness due to a variant strains of this virus. For example, if I only use one single MAB, that is a monoclonal antibody, this may actually attach to one particular epitope, and if the virus gets mutated or it gets a new variant, there is likely possibility of escape of this virus from this monoclonal antibody inhibition, and may not be effective. So if I have a combination of two, there will be two overlapping non-overlapping epitopes which gets inhibited. So there is a less likely chance that the virus has a particularly mutated these two combination of epitopes. So the chances of escape are less likely. So where from the literature comes in support of whether I should get a shot or not. The reports and the literature comes from this Regencov study, which is original study, which is published. The clinical question is whether resin-CoV-2 reduces the viral load, leading to improvement and reduce the medical attendance in outpatients in COVID-19. This was the question. Then the design was, it is a multicentric randomized double-blind trial, which is phase 1 to 3 clinical trial involving around 275 patients. The inclusion criteria was around adult patients more than 18 years with confirmed COVID-19 infection within this last 72 hours of randomization and symptom onset not more than 7 days. That is, in between 7 days of symptom onset, within the 72 hours of COVID-19 confirmation. And the exclusions were those who require hospitalization, those who were already received other monoclonal antibody or IVIG, and a convalescent plasma, so they were all excluded. So these 306 patients who are eligible, 31 were excluded, and then they were divided into 3 groups. One group of 93 as a placebo, one group of 92 who received 2.4 grams of this resin-CoV, that is a combination of one kind of monoclonal antibody, and the other one is 8 grams. So this is a comparison of placebo, 2.4 grams and 8 grams. And at baseline, there were almost 50%, that is 45% of patients who are seropositive, and there were around 40% who are seronegative, and the rest were of unknown antibody status. So all the 3 groups received a high dose, low dose, and placebo, a saline of 250 diluted in them over 1 hour. And these are the different key endpoints which were looked at. From the baseline serum antibody status to those who has positive, negative, and those who has unknown groups. And the final analysis of patients who had more than 1 visit in 29 days and those require hospital visits were considered. And they also considered the difference in viral load from the different timelines in the 2 different groups of 2.4 gram, 8 grams, and placebo. In the upper, if you can see the viral load in the both resin-CoV-2 8 grams, resin-CoV-2 2.4 grams in a different kind of times, 3 days, 5 days, and 7 days, has been significantly lower in the 3 groups compared to the placebo alone. Whereas in the lower, if you see the more the viral copies, the chances of its rapid drop of the viral load was comparatively more. And if you can see the upper part of the last slide, where you have a comparison between antibody negative and antibody positive. Antibody negative patient, the viral load has comparatively significantly had a better recovery and decrease in viral load compared to placebo, whereas it was not seen in patients where antibodies were positive. So the results of resin-CoV enhance the clearance of viruses, particularly in patients whom an endogenous immune response has not yet initiated. That means in patients where serum antibodies were negative, who had a high viral load at the baseline, these patients had a better viral clearance with this combination of resin-CoV. And the clinical efficacy in seropositive group had a significant compared to the non-seropositive. And whatever it's a safety profile, resin-CoV is safe, and the adverse effects were also comparable to placebo, and now significant adverse effect has been seen. So limitation, it was a small sample, and it is on viral load, not on a patient-centric outcomes as we generally look at mortality or hospitalization. So these were the innovations in the initial part. So there comes this new phase 3 data, which was investigational antibody cocktail in carcinomab and imdevimab, reducing hospitalization and death by 70% in non-hospitalized patients with COVID-19. So there are 2 groups in which resin-CoV 2067 were high-risk non-hospitalized patient with COVID-19. There was another group with 20,145 that is low-risk asymptomatic or symptomatic non-hospitalized patient with COVID-19. So these two groups which are in phase 3 randomization placebo-controlled double-blind trial. The population are included as adult, which are symptoms onset less than 7 days, tested positive less than 72 hours like that, and they are randomized. They are randomized into 4 groups, and they were compared like 1.2 milligrams of IV in this combination. That is what we recently are using with placebo, and then 2.4 milligrams IV with placebo. And patients with more than one COVID-19 related hospitalization or death through the 29 period were compared. And they could see the risk reduction was around 70% in both the groups. And there was no difference found between the doses of 1.2 and 2.4 grams. That is, both had a similar count of risk reduction of hospitalization or death. So in phase 3 randomized study to assess the antiviral effect across the different intravenous and subcutaneous doses compared to placebo. So this trial showed significant and comparable viral load reduction across the ranges from 300 to 2400 milligrams. So this is again another phase 2 randomized trial which actually showed the risk reduction. So these are about the drugs which are available in India till this time, that Rosin-Co, the combination of the antibodies which are available in India. But the other two monoclonal antibody, that is Mavlenivab and Itezimab, which has been also studied in outpatient management, that is BLAS1 multi-part trial, which compared the Mavlenivab as monotherapy or in combination therapy with Itezimab on viral loads in patients with mild to moderate COVID-19 patients, and Mavlenivab plus Ezetimibe in mild to moderate COVID-19 patients. There were 2 trials which were done. And these trials actually were conducted in randomized double-blind placebo trials. They taken adult patients having 1 or more mild to moderate symptoms and presented with 3 days of the first positive test results. And this was conducted in from June to September. And these were exclusion criteria, those who had severe hypoxemia, and those who actually are pregnant and breastfeeding, and those who received a convalescent plasma. These are all been excluded. And these are the groups which has been assigned. One group is assigned 700 milligram of Bamlanivimab. The other group received 2,800 milligram of Bamlanivimab, and the other group received 7,000. This is 3 different doses of 700, 2,800, and 7,000 ml of Bamlanivimab, which actually compared these 3 doses of same drug of same monoclonal antibody, comparing with a combination of 2,800 milligram of Bamlanivimab and Ezetimibe. So this is again a combination of these 2 drugs which has been compared with the other 3. And these again compared with placebo. And the outcomes were the hospitalization and emergency visits were significantly lower in combination or even in a one single monoclonal antibody. So the conclusion was, among non-hospitalized patient, treatment with this LAIS-CoV was associated with statistically significant reduction in viral load at day level. Further ongoing clinical trial will focus on assessing clinical benefit was the part. And this is again another trial which actually compared Bamlanivimab plus Itezimab in mild to moderate COVID-19 patient. And this shows the comparison with the combination with placebo, a significant reduction of both the patients requiring hospitalization and death compared to a placebo. There is also a reduction in the viral load from baseline at day 7. So the conclusion was, among the high-risk ambulatory patient, this combination led to a lower reduction incidence of COVID-19 hospitalization or death. So based on these evidences of both the Rosin-Co and LAIS-CoV, both these from Eli Lilly and Regeneron, the FDA granted emergency use authorization for this combination for the treatment of mild to moderate COVID-19 in non-hospitalized patients who are at risk of progressing to severe disease. So with continuation to this approval, CIPLA got the approval to actually brought this ROS drug through the Central Drug Standard and Control Organization in India, and provided emergency use authorization UAE for Rizincov cocktail in India. And this is marketed and distributed in India through a strategic partnership with CIPLA. And the combination of authorization which came to India is casirivimab and imdevimab. So this is the cocktail which is right now available. So till now, if you remember, we have only discussed the drug, both these combinations, either in the combination of balmavinab or the Rizoncov, both are only for the non-hospitalized patient not requiring oxygen or patient in prevention. But the same combination is being trialed by recovery group in a hospitalized patient. And this trial previously shown to the same group as previously shown the dexamethasone tocilizumab used in hypoxic patient. So the same group also considered the carcirimab and imdevimab combinations used in them. So again, this study was randomized evaluation of COVID-19 therapy, and between the September 18, 2020 to 22 May 2021. And these are on all admitted patients to the hospital with clinically suspected and laboratory confirmed SARS-CoV-19 infection were eligible. Patients who had received intravenous immunoglobulins and current admission and children aging less than 40 kilo, less than 12 years were excluded. So around 9,785 patients were randomly allocated. And in that, 32% were seronegative, 54% were seropositive, and 14% had unknown status of the antibodies. And patients allocated to Rizincov received a single dose of Rizincov. That dose is 8 grams. Earlier, we only spoke about 1.2 grams. Now we are talking about almost 8 grams. That is almost 6 to 7 times of the dose we are talking about. So in that, there is a combination of carcirimab 4 grams and imdevimab 4 grams in 250 ml of 0.9% saline. And this is a very high dose compared to the earlier used doses to prevent the infection. And what did they found? They have taken seronegative, seropositive, unknown antibodies and to different with comorbidities, and baseline characteristics were matched. And these were different other drugs which were also combined with them. So the results were found to be the seronegative and seropositive group. If you compare those who actually had a seronegative, the Rizincov group had a much lower mortality, but in seropositive group, the Rizincov and usual care had no much difference in mortality. And when all participants were putting together, there is also no much difference between the two groups. So if you compare this again with the Foster plot, again that says that seronegative group had a better advantage of overall outcome and even mechanical ventilation come to the seropositive group. So there was no significant difference in outcome like progression to renal replacement therapy, non-COVID mortality, cardiac arrhythmias, thrombosis or major blood either in the seronegative or overall population. But safety profile of the treatment group was similar in both. So this is again safety profile wise in both the categories seronegative and seropositive. It was found to be safe, not having any significant adverse outcomes. So in conclusion, in this large randomized clinical trial, the first evidence that Rizincov can reduce the mortality in hospitalized COVID-19 patient, and the results support the use of Rizincov in seronegative patient hospitalized with COVID-19. So just to actually summarize, in our outpatient, we use this kind of casirivimab 120 milligram per 120 milligram per ml, which comes for a 10 ml. Out of that, we only take half of the carcirimab, that is 600 milligram of carcirimab and 600 milligram of imdevimab, and that is costing somewhere around 60,000 approximately. And this is half of the total 2 vials which we get, 2 multi-dose vials which we get. And this one combination set we can use for 2 patients. And this will be only for those who are either we give in prophylaxis or we give in patients who actually are not requiring hospitalization but are high risk of getting hospitalization from a mild to moderate symptoms. So these are to prevent the progression, and this is the dose which we use. In hospitalized patients who are on either oxygen or on a ventilator which the disease has progressed and they have a seronegative, the dose which is required is 8 grams, and that will cost somewhere between 3.6 to 3.8 lakhs per patient. And this is shown to reduce the mortality in patients who actually were less than 7 days of the disease and seronegative, and this dosing has been higher. So there is again another data from subcutaneous use. These are all IV use, subcutaneous use to prevent symptomatic and asymptomatic COVID-19 infection in previously uninfected contacts of infected patient. This is all like a high-risk group patient has been exposed to a COVID patient, and to prevent the infections in that particular patient or the progression in that patient, they used subcutaneous resin cove to see that this does not progress. So with this information, the monoclonal antibody cocktail therapy has shown benefits, and I think this needs a sort. The question to answer is whether this needs a sort or not. I will recommend this needs a sort in patients to prevent hospitalization in COVID-19 infected outpatients who are at high risk of severe disease. Who are the high risk group? The high risk group are the patients who are more than 65 years of old, those who have a multiple comorbidities like obesity, hypertension, diabetics, or any other organ involvement like CKD, CLD, or any respiratory elements in their background, or a immunocompromised host who are on immunosuppressive therapies, those patients who actually are in mild to moderate symptoms and in the early part of the disease. These patients can get benefited by monoclonal antibody cocktail to stop the progression. And particularly this may reduce the mortality in a seronegative hospitalized patients who are on ventilators or on oxygen therapy. Within the first 7 to 10 days, these patients with higher dose compared to 1.2 grams of combination, these patients may need 4 grams of each. These may have also a benefit. There is also a component of post-exposure prophylaxis, both in IV and subcutaneously. In high-risk group, after the exposure, before the symptoms, these patients may get benefited. And there is a comparative study between 1.2 grams and 2.4 grams compared to the 8 grams, and there is not been in outpatient basis without any significant symptom. There was no difference in the outcome in the different doses, but in patient with hospitalization, the higher dose was shown to be beneficial, and the further studies which are going on comparing 8 grams with 2.4 grams and 1.2 grams in hospitalized patient may give a further information whether in hospitalized patients also we can use in the lower doses. The safety profile of monoclonal antibody has been found to be very safe, because there was no major adverse effect except some drug-related reaction, or very few anaphylaxis were found. Rather than that, there is no significant any benefits adverse effects has been found. And there are further studies on anti-cytokine antibodies which has been under trial, which we probably need further time to evaluate. There were our clinical experience we used almost around more than 400-500 of this monoclonal antibody cocktail to many of our patients. We have not seen any significant adverse outcome in them, and majority of our patients has not progressed to any severe disease, but very few do progress to a requirement of oxygen, and few of them also needed ICU, and very few have also landed on the ventilators, and we lost a few. That means monoclonal antibody may not protect you 100%, but yes, there is a reasonable good percentage of protection, or a what you say, the safety which these monoclonal antibodies do give us. So I feel at this point of time, the monoclonal antibody cocktail should be considered a sort in patients who are at high risk of disease progression, and those probably are hospitalized but having a seronegative state. That means antibodies are negative and are an early part of 7 to 10 days of disease. But the dose is higher. At this point of time, the data is for a higher doses only. Cost is a concern. We need to wait that whether the lower dose can also be considered in that as well. Thank you.